So good morning, good afternoon, and good evening, everyone. Welcome to our webinar today. My name is Olive Kokeman for the Network for Improving Quality of Care for Maternal, Newborn, Child and Health with the Secretariat of the World Health Organization. This is our first webinar in our series on the national forums across 2021 and 2022. In 2017, 11 countries came together to participate in the Network for Improving Quality of Care for Maternal, Newborn and Child Health. They came together with the goals to halve maternal and newborn mortality in health facilities in network countries, as well as stillbirths by 2022, and to improve the experience of care. This was to be achieved by 4 strategic objectives: leadership, action, learning, and accountability. This webinar series aims to share that learning. Our agenda here is to document that learning and share it within and between countries. This is a key objective of the network to undertake this task. It's a very important objective in order to support policymakers, managers, and providers to have the opportunities to exchange and learn from each other, to share their challenges, their practical solutions, which are saving lives with quality and dignity. The exchange is needed at the national level, as well as among the network countries and with broader partners. So the national forums on quality of care for maternal, newborn and child health provide a venue for sharing experience in the adapting and implementing the MNCH standards, also on the quality of care network strategic objectives and progress towards achieving the SDG goals for maternal, newborn and child health, including within this COVID pandemic. The objectives of the forum broadly are across these 4 points. Each country, indeed, relative to their own context, can set the objectives for their forums as pertinent to their individual needs. We establish these 4 broad objectives, discuss how the network strategic objectives have facilitated the acceleration of activity in country, to share examples and experience across the standards, the quality statements, the measurements, and interventions in learning districts, and discuss the implication for scale up to the subnational and national levels. Also to document those best practices across the countries that will be shared at a global forum in 2022 and in other global learning events. And finally, the national forums are a venue to acknowledge, honor country level actors and actions that have advanced the network milestones and objectives. In order to structure those lessons across all the participating countries in the network, we undertook a process to determine how do we prioritize those lessons that need to be documented. We drew from the findings of the quality of care in the network progress report that launched May 4th this year, that was documenting the progress over the 4 years to date. Drawing on those findings and also with a survey that was undertaken with partners and all stakeholders in the first quarter of 2021, we came to a curated list of lessons. Under each strategic objective, we have set here lessons that we would like each country to work to document. And we'll be sharing those in this webinar series. And so today we have our very first webinar, establishing the sharing of learning, the documentation of learning. We will be presenting across these 4 areas the specific points under each. You'll be hearing shortly from Dr. Margaret Manna from Sierra Leone, and you will also hear on any other pertinent issues that Sierra Leone would like to share at this moment in terms of their learning. So at this moment, I'm going to hand over the presentation to Matron Margaret Manna, who's going to present to us. Firstly, I will give the floor to Martin Dahlstrom, who is our lead, our technical lead at WHO in the Secretariat, working very closely with all the country offices. So over to you, Martin, to take the floor.
Thank you very much, Olive. And I'm very pleased to present to you Matron Margaret Manna, who is the program manager in the National Quality Management Unit in the Ministry of Health and Sanitation in Sierra Leone. And she will present on Sierra Leone's experience from their national forum, but also a bit on the impressive journey Sierra Leone has undertaken in their efforts to improve the quality of care for maternal and newborn childhood. And also, as this is the first presentation of this webinar series, as we will hear from more countries in the coming months, we will learn that each of the countries' journey is different and the context in which they operate differ in many instances. So hopefully this can give a broad understanding of various efforts undertaken to improve quality of care, and we can also learn from and be inspired by successes and failures and how it can be documented, shared, and implemented in the various types of contexts. But with this, I would like to hand over to Matron Margaret to take us through the inspiring journey that Sierra Leone has done. So Margaret, the floor is yours. Margaret, you are on mute.
Thank you very much, Martin. Thank you very much, Olive, for the wonderful introduction. So, of course, good afternoon, everyone. I will be presenting on behalf of Sierra Leone's quality of care journey so far and the experience during our first learning forum. So, as you can see, can you see my screen?
Yes.
Okay, thank you. Thanks. Okay, so basically this is the outline, as you can see. We'll be taking through this afternoon. So this was what we used, and you will see all the partners who supported. Their logo is on it, thanks to them. So the first part will be the MNCH status in country, in Sierra Leone. So as you can see, Sierra Leone has a population of 7.8 million, and out of that, we have an estimated pregnant women of 35,000, wherein we have 51 hospitals and 1,200 plus peripheral health units, and we have at least a nurse and doctor or midwife ratio as a country. We have high ANC1 and ANC4 coverage. There is increased institutional birth rate and 87% skilled birth attendance. And well, early initiation of breastfeeding at least is relatively low, but it's better now, we are capturing. And we have newborn dried 81%, and health-seeking behavior at least is improved. But out of all these process indicators, our outcome indicators have been very bad. As you can see, currently we have a 717 per 100,000 live births of maternal mortality rates. Then we have stillbirth rate of 24 per 1,000 and newborn 31 per 1,000. We have increased adolescent birth rate and under 5's mortality. Then life expectancy is 54.3. So out of this, we have realized that though our process indicators were very good, but the outcome indicators are bad. So as a country, poor quality of care was identified as a major contributing factor to the poor health outcomes in Sierra Leone. So to that, we have a very good political commitment, and the ministry, they developed the MNCH strategy, which is the investment case for Sierra Leone, that has its goal of accelerating reduction of the preventable deaths of women, children, and adolescents, and ensuring their well-being. So out of that, the target that they set was to reduce the high maternal mortality ratio, at least from 1,165 to 650 per 100,000 births by 2021. Then also to reduce the neonatal mortality rate from 39 per 1,000 live births to 29, as well as stillbirth ratio. These are aligned to the global QED network target. So Sierra Leone actually tried to fit into that. Currently, in terms of quality of care progress, I will be discussing around the LALA framework, that is the leadership, action, learning, and accountability. So for leadership, Sierra Leone actually developed the QAC strategy, and that was aligned, as I have mentioned. So for leadership, we actually try to see how we strengthen national institutions and mechanisms for improving quality of care, accelerate the sustained implementation of it. Then for learning, we want to share and generate evidence like I am doing today, and in terms of accountability. So we held the National Forum in March 2021, and these are the objectives that we set ourselves. We wanted to discuss the progress that we have made so far, key challenges and lessons that we can learn moving forward the QAC agenda. Also, we want to inform the next steps and future direction of QAC implementation nationwide. And we wanted to provide a forum for learning on quality of care as well as patient safety. Then we looked into the activities of the coming year, and we really used that particular forum to strengthen our relationship and partnership between government, our donors, and other stakeholders. So initially, these were the principles that we used for the learning forum. First, it was led by government and owned by my person sitting here and the Ministry of Health and Sanitation. Then learning facilities were at the center. Additionally, the clients or beneficiaries or users that comprise of civil society, the regulatory bodies, they were the backbone of every initiative that we did. And we had partners as catalytic agents that supported for this particular forum to be held. And we appreciated our donors, the investment they made, and also for future sensitization, as Sierra Leone QAC agenda is relatively new. We'll see from the slides as we go along. So basically, using those particular strategic directions, I will now start to say, using leadership, we prioritize learning. So in terms of leadership, this country wants to put behind their back the needless deaths of women, newborns, and the children. So as a result, Sierra Leone joined the QED network from a presidential request in 2017. Sierra Leone was enrolled within the QED global network. When we came back home, the actual process started in 2018. So in 2018, we had a very good political commitment wherein the current government had it within their manifesto document, that's the acronym, the new direction. They clearly stated that this country has an under-resourced, ill-equipped, dysfunctional healthcare delivery, and they want to make it high quality, efficient, reliable, cost-effective, affordable, and sustainable. That's the president during the fifth opening of the fifth parliament, the state opening of the fifth parliament. Additionally, after they have constructed one of the maternity units or sent facilities, during the commissioning, he clearly stated that the thrust of the new direction government is to increase access to quality health services for all population, particularly mothers, children, and the elderly. So if you see, that's the president and the Honorable Minister of Health then, Professor Alpha Tiuri, and our current president during that opening statement. So in terms of leadership, they actually set up a small secretariat and established it in 2018. So in 2018, I think it was around November or late December. So we had now it transformed into a program, and the program actually started in January 2019, where they have me as a program manager, as well as a quality of care officers within the unit. Then we established district and facility QAC committees in 2019 as well. We had a national technical working group that was established and a national steering committee. These are pictorial evidences of the steering committee and the TWG meeting where we discuss quality of care as an agenda. For leadership during the forum, we used 4 approaches. We had a panel discussion, we had PowerPoint presentations, we had group work, and we have poster presentation. So during one of the panel discussions, we had leadership management and coordination for quality of care with a key objective of really trying to see a stronger leadership management and coordination for improved RMNCH outcome. And out of that panel discussion, we have key reflections. QAC actually needs high-level support from President to the Ministry of Health and Sanitation. Then we realize also that effective communication, appropriate leadership style, and strengthening teamwork as very key for quality of care, as well as transformational leadership, where change should be intrinsic. It has to be innate for you to see how you can move other colleagues to move on. Then, as well as we need to have competency-based appointments into positions and also performance-based management. There was need for us to review the existing organogram and need for us to create QAC structure at district and facility level. And healthcare workers need to be motivated, retained, and redistributed. Additionally, we had another panel discussion around regulation. As you can see, the regulatory systems in the country needs a lot of strengthening. So we have the registrars of the three main regulatory bodies, pharmacy, nursing, as well as the doctors. So current regulatory bodies, the key reflections that came out of them, the discussion was there was need for independence and autonomy. Then there was need for it to be well-staffed and financed. Then the regulators need to be accountable for issues such as medical malpractice, license and relicense, and the right. Then we also they need to be supervised. Then it comes to my mind, who is regulating the regulator? These are all issues of concern. So the Nursing and Midwifery Board currently needs to be transformed to a council where it has to be autonomous, it has to be self-governing, and they should be able to really see how nursing and midwifery is being accounted for in this country. Then we need to follow set standards in terms of ethics, in terms of guidelines and policies, because there is a lot of inadherence to some of these statutory documents. Then we need to enforce that these laws, the standards and guidelines need to be implemented, and people need to have integrity. We need to be authentic. We need to be honest to the people we are serving. We have another forum where we are trying to see whether aspirations we have can be put into action, where programs need to be transformed to become proactive leadership, where you need to take action rather than somebody coming to see your fault or to see issues around. So some of the key reflections that came out of that particular discussion was there was need to avoid assumptions and generalization. Most often when health workers are there, because of the title or nomenclature, we assume they know, or we assume they understand. We assume they will be able to provide the right kind of services or knowledge that we aspire to them. Then we realized there was no demand for data for decision making. Okay, yes, they generate the data, they collect it, they analyze, but are they using it? So moving forward, we realize people should look at their data, the facility data, or even district data for them to be able to develop their annual plans or even quarterly plans. Then leading by example, are we role models? So that came out clearly when we had those discussions, and there was need for comprehensive planning. So it should not just be inherent within the district, but they need to use those data to solely mobilize resources and also source funds. The other thing that came into that particular discourse that day, there was little awareness of the partners' activity by the district health management teams. There is limited coordination platforms, meetings, limited exchange of plans, and waiting for others to come rather than DHMT actively coordinating. So these are some of the issues that actually came up that day. So using the LALA framework, I am now giving you what came out from the action side, wherein we are trying to link the MNH QI implementation to decision-making process at facility and also aligning it to the local health systems governance and also advance the QAC agenda. As you can see from this slide, currently Sierra Leone has the QAC and patient safety policy, wherein we set ourselves that we have to have set standards on safety, timeliness, effectiveness, using the dimensions of quality of care, and quality assurance system has to be in place so that the overall quality improvement activities will be implemented at facility so that we are able to fulfill the consumer needs. Quality needs to be mainstream in pre-service education and training, wherein at least people need to know around quality and quality of care before they graduate. So by the time they are coming, there is no need for us to waste more time to catch them up with the particular issue. So we currently have a quality MNCH strategy where we want to ensure that mothers, newborn children, and adolescents receive quality of care throughout pregnancy, childbirth, and postnatal period, as well as we want to see continuous improvement that will be geared towards reducing maternal, newborn children, and adolescents, and half institutional maternal and newborn and child death as a country. That's the picture of the two documents. Currently, we have our training manual for QI as well as coaches manual. Thanks for the support of WHO and other partners like UNFPA and IHI Ubora Health. Then also we are having sensitization on quality and quality of care and its dimension to our partners. That's ongoing. Then we are about implementing our change packages to reduce maternal, newborn, and child and adolescent deaths. That was developed in 2020. It is still ongoing. Then experience of care tools actually were developed in 2019 and 2019, and it was piloted in 2 of our districts, and the results actually is really interesting, but that will be for another forum. And currently, training of coaches and other healthcare workers in terms of facilitation skills and quality improvement methodology has been undertaken. So during that panel also, we had another discussion around respectful care and experience of care. These are new concepts that are coming towards coming into the country. So we really wanted to at least share thoughts and have a reflection around reducing neglect, abuse during labor and childbirth, as well as trying to improve the experience of care of our mothers. So the key reflections that actually came up that day was the staff needs to be equipped with knowledge and skills on accountability framework and respectful care provision. Then we want to use pre-service curriculum and preceptorship as a tool for compassionate care strengthening in our facilities. Then there is need for continuous positive staff criticism, appraisal, and reward system to keep them motivated. We need to ensure existence of feedback mechanisms. We have like suggestion boxes, but most of them, they are overlooked. So we really want to see how we engage the community for them to be able to provide independent feedback so we know how to plan better for them. And we realize that economic issues of the staff should not be used to prevent women from getting the needed attention that they need. Then the environment also needs to be welcoming and conducive, because our facilities, as you can see, some of them are not really conducive for some of these interventions. Then another discussion was around referral system. Referral system, as a country, we have the National Emergency Medical Service that we call NEMS, has been providing. So key reflections that actually came up was there is high demand for ambulance supply. And in terms of availability, now we have real-time data for action. And the number of referrals and referral points, service availability and bed occupancy, these informations actually are known today as compared to how it used to be. Then the other thing that actually came up, we have silent chiefdoms of facilities that has never made referral to the next level. So it came to our mind, is it that people are there, they are not coming to facilities, or are they dying, nobody knows, or are they telling us there are no complications? So these are all things that actually came up during that discussion. Then there is lack of clear standard operating procedures on referral and ambulance service. Then the referral needs to be linked with the ambulance and free healthcare services and not seen from just the health system strengthening perspective. COVID actually has impacted referral pathways and number of referrals. So we are still having issues around poor road network and mobile phone or phone network challenges that will support referral as a country. In terms of learning, we actually try to see how we can share knowledge that we have got across the district so that that can be scaled up. So it informs Sierra Leone. We normally, in terms of leadership, we have our QIT meetings regularly. Every facility, every district have their own timing independently. Then you can see from the pictorial evidences where they are having meetings. Then that was a picture from our National Learning Forum. So if I can come to really give you an insight of what's happened, the slide I am sharing is we have our 41 QI projects that have their targets, the progress, the challenges and outcomes we have presented. So we have 6 district presentations on poster. Then we have 20 projects from hospitals. Then we have 20 as well as from the peripheral health units. So 15 posters were on maternal issues, 10 on newborn, 5 on child health, and 10 on health system issues. I am now presenting the poster presentation that was looking at how to improve monitoring of blood transfusion for it with the main purpose of having safe blood transfusion. So these are the change packages that they developed, as you can see, and these are the observations that they used using the heart rate, respiration, temperature, oxygen. This slide will be shared for you to know exactly what came up. Then we have another poster presentation in trying to reduce surgical site infection that we have seen is contributing to be the 3rd highest killer of our women as well as newborns in health facilities. SSI is on the increase. So this one was actually presented, and as you can see from the project presentation, wherein they were monitoring the runs every monthly, and this was what the change package that came out of the SSI Pro QI project. Then we have another one that was really trying to improve the time of decision to incision in one of the facilities. So this was what came out of it, and you can see the posters presenting, and these informations are online as well. Then we have another one on improving screening for hypertension. So they, in their own facility, hypertension was one of the leading morbidities within their facilities. So this was what they used actually to come up with a change package. We have another one on reducing hypothermia because it was an incident among the newborn. So these were some of the change packages that they developed, and this was how the QI project was progressing. Now, we used research publications during the forum. So a research paper was published on pepper injection. That is local name for oxytocin injection. So this particular work look at trying to create awareness around the risk and the prevalence of use of highly concentrated injectable oxytocin. And the key finding actually was that improper and harmful use of oxytocin was widespread and of grave concern in Sierra Leone. So it might be a major contributor to maternal and newborn morbidity and mortality in terms of high ruptured uterus and stillbirth. So that particular publication is available as well. Then we have another one on maternal cesarean section infection as a case control study. And the primary finding was that 1 in 10 women undergoing cesarean section in one of our teaching, our principal teaching and referral hospital for OBS and gynae in terms of SSI, that it was contributed to 5.3%. Then it's a predictor that the social and demographic, that is being single, you are unemployed, low educational status, or having an abnormal BMI, these are all contributing factors to the high incidence of cesarean section infection. And there was need to urgently tackle SSI so that antibiotic required appropriate administration and closing also were issues that actually came up. So this was what that paper found out. Then the rate of perioperative mortality from cesarean section in Sierra Leone was also another publication. So these are the key findings, as you can see from my right-hand side, that came out of that particular publication. Now, in terms of accountability, we are actually trying to see how we strengthen routine measurement systems so that we are able to collect quality data, we report them, and we can use the QAC indicators to help improve and sustain quality MNH care. Then we actually try to develop and implement accountability mechanisms that can integrate into community and stakeholder perspective. So if you see, these are some of the accountability activities that we are implementing as a country, wherein capacity building is done for our M&A officers. Then we have developed QAC indicators that are regularly updated. We have done assessment of medical records management, and the data quality audit is being done. Then also we have developed and we are now implementing a scorecard by the grace of God. So these are the data systems for quality of care that we have employed in Sierra Leone. Now I am sharing a slide for you to see how the maternal death reporting looks like in 2016 on to 2020. So you can see the trend from the slide I am presenting in terms of our maternal death reporting as a country. So because we have those systems, we have now been able to really know how much are they dying, where are they dying, and what are they dying from. And basically, I am giving you another slide of key morbidity of our women as a country. We are still having issues around hemorrhage. And if you look at hemorrhage, it's postpartum hemorrhage. So along these lines that we manage to develop our change package for maternal complications as a country. Hemorrhage is still a leading cause. Second to that one, we have hypertension, that is preeclampsia and eclampsia, and we also have sepsis or infections and other obstetric complications. Maternal death, the trend in selected learning facilities. We had like a 4-district presentation. We started from 2018, 2019, and 2020. The one you see, PCMH, is the main referral and tertiary facility that's located in Freetown, where all the districts refer women for obstetrics and gynecological problems. So that's why you see them, they are having the high bar. Then I am also sharing another slide around stillbirths that we are now collecting as a country since 2017 to 2020. And now we know how much. If you look, 2019 is 34. 2020, for now, we have 17.9. We hope it will not increase more than that. I am also sharing another slide on stillbirths per 1,000 live births. So it's just giving you a graphical illustration within the 4 regional district facilities and PCMH hospital. So in our group, we try to see how we integrate community and stakeholder perspective. That is the action now. So we had insights. We actually try to have the PHUs, we engage them for quality improvement. And the key reflection during that particular discussion was there is a lot of community fatigue. This aspect, I don't know whether the initiatives that we use immediately after the war, where we have maybe money for work or we have cash for work project, people now still, even something that they can do, they are requiring incentive for them to be able to really support. Then we still have issues around irregular and sometimes no feedback collection mechanism from communities to our facilities. Then there is dysfunctional facility management committees and limited awareness of existing community health policies, then lack of community scorecard and poor participation of our communities and our clients in facility and district planning. So these are some of the key insights or next steps I am presenting that came out from this particular conference. We need to transform the regulatory system, complete reform, not halfway. If we want to see accountability, we need to transform. We need to create QAC structures at district and facility level organogram. We need people, dedicated officers. We have learned since we started 2019. Once we train somebody, we say this is our QOC officer. That person has different chores that person is undertaking. So commitment to quality of care agenda in a facility or at that district has been really hampering. There is a lot of attrition. Sometimes you go and the person has been transferred to other places. So now we actually came up that we needed dedicated QOC officers and capacity building on quality management. We need to strengthen our national and district or facility coordination platforms. We need to strengthen facility and district learnings. We need to mobilize partners to provide direct support for infrastructural development. Because if we want to see respectful care, we need improvement in terms of our infrastructure, the way they were, so that they can accommodate. Sierra Leone, we don't have a patient charter, so we need a client charter, and health workers need to be oriented around it. Then we need to conduct experience of care survey in selected facilities, maybe through exit interviews or the like. And QI capacity needs to be ongoing and it has to be strengthened. Then virtual meetings with district and learning facilities need to be held regularly. We need to improve data quality and feedback mechanisms, as well as develop our community scorecard. Then also common core indicators and the national core indicator dashboard need to be developed as part of the DHIS too. Then we need to conduct planning forums at least every 6 months. So at this point, I want to break and say thank you. That is our local pigeon, to say thank you for listening. And I wait for questioning and maybe if you have concerns to raise. So thank you very much for your attention.
Thank you very much, Matron Margaret, for this very exciting and comprehensive experience that you shared. And it's very impressive to hear the journey that Sierra Leone has undertaken. And as you mentioned, it's the quality of care from MNCH. It's also quite a new commitment in the country, but just in a few years, you really managed to set structures in place and also provide some results in terms of quality improvement projects, setting up systems, etc. So it's very impressive. And also just to mention that Sierra Leone was actually the first country of the quality of care network countries to help the national forums. So this is also learning for us and other network countries and other countries also for that matter. And we're very impressed in what you did. So we've had a few questions coming in. So I would like to address those, and I'm sure more questions will follow. But just so the first question would just be based on the National Forum, what would be the way forward, both in short term and long term? And I think that would be whether the National Forum will be a standing event for Sierra Leone, and also in terms, as you mentioned, in terms of the regulatory bodies, etc. How will you now move on from the findings and discussions in the national forums? So that is one question. And another question was in terms of referral. So I would take two questions and then you can answer, Margaret. In terms of referral, when you talk about ambulance, what do you mean? Is it really transport or staff in the ambulance provide care for women, newborns during transport? And that would say, do you have any paramedics? So if you would like to address those, then we will have another set of questions after that. Over to you, Margaret. And I'm sorry, you're on mute.
Muting now. Thank you very much, Martin. And thanks everyone for actually asking questions around that. Yes, if I may start, short term and long term for the National Forum. We want, well, based on the resources, we want the National Forum to be a standing order moving forward, because bringing people, it's really brought sharing among the colleagues. People were able to see other QI teams and other colleagues from other districts and other facilities they interacted, they have like one-on-one dialogue, and they share their experiences. So moving forward, and you know, this particular forum brought a lot of awareness among even the partners in country. Immediately after that forum, I will tell you, my office has been very busy. We have new partners like the Momentum USAID with USAID support. They are now coming because people like have been implementing QI activities, but it was like in silos. But now at that forum, we were able to showcase what people who have mainstreamed their activities with the National Ministry of Health program were able to showcase. But now moving forward, I think they have seen what the National Forum brought, and we want to maintain it as a standing order. Then in terms of the regulatory system, you know, it was so interesting for you to have the registrar of the 3 professional bodies in that particular forum where they shared thoughts and ideas. That has never happened. So moving forward, we are now working with them, and we have given feedback to the ministry. We are now seeing how we work with them to see how we mobilize resources to support them in terms of making the regulatory bodies more independent, more autonomous, and more accountable to the people of this nation, and why not to globally. Then ambulance. Ambulance actually is a vehicle, is a vehicle, is a car. But we have the national ambulance system. Then we also have the one that initially we never had a national ambulance system. But I think post-Ebola actually led this country now to have a national ambulance system, wherein selected in all districts, they have ambulance that is located within the district health management team office, and they have them in selected chiefdoms, that when you have issues around complications, you can just have a call and the vehicle can go and pick that person up, then they come. However, we still have issues around the road network and communication. Some of the areas, people have to either climb trees to make phone calls, or they have to climb mountains because it's so deep in the valley that they cannot access it. But in the cities, it has been very useful. Ambulance is a car. I don't know if I have pictorial evidence that I can just show, but that's how it is. I have my colleague here. Maybe he'll throw some light in the question. Biniam?
Thank you very much. Okay, can you hear me?
Yes, there seems to be some echo from your end, Binyam.
We are really sorry. Yes, Biniam?
Yeah, thank you. It's just to shed light around, the ambulance in the referral system. It's a national emergency medical service, Sierra Leone, with high reported number of maternal and child deaths, and with an initiative of free health care. It came to the president agenda that access to emergency medical service is critical, and the first step was to put in place enough ambulance to facilities, particularly referral facilities. Then after having some period of ambulance service provision for like quite 6-7 months, then it came to attention of the ministry that we need to have more paramedics, people who can really accompany particularly health workers to the referral facilities. So now the ministry has already engaged paramedics who have been trained on emergency medical care, and currently these people, particular cadres, accompany all the referrals. Thank you very much.
Thank you very much for addressing those questions, both Margaret and Binyam. And it's interesting also, Margaret, that you mentioned also how, you know, from the experience of Ebola, how then the referral system was strengthened, which will then also, of course, play into the efforts in promoting and strengthening the quality of care. So in line to that, I would like to move into another question, which is quite broad questions, which we received, but I think it can be a bit integrated in that. As you mentioned in the statement from your president, he said that the health sector was under-resourced, ill-equipped, with inadequate infrastructure. And, you know, these are so impressive, the QAC strategies, but can the work, you know, the QI work that's undertaking, how do they persist, you know, if these problems exist? And is there now more funding, more better infrastructure, more resources? And maybe that can also build from the events that has been taking place in Sierra Leone, such the Ebola, COVID, for example, that these questions now have been addressed better from a leadership point of view. So that is one question, if you can just note that down. And also another one which touch upon if there's been any engagement in the traditional birth attendance in the maternal health framework. So those two questions are for you, Margaret.
Okay. Thank you very much, Martin, and thanks everyone. Yeah, well, yes. Currently, the Ministry of Health, the government of Sierra Leone through the Ministry of Health and Sanitation, they are now developing more plans, and more resources are now being mobilized. And the government, actually, the Abuja Declaration mentioned at least 15% GDP towards health. And I think 11% currently is being allocated to health activities. And more institutions of learning are now being undertaken, so that will have more competent staff, because the staffing situation, the human resource situation in this country is really bad, but gracefully, it's gradually improving. Currently, I will tell you that we have like 3 midwifery schools, although we still have a lot of maldistribution, but however, it's better as compared to how it used to be. And at least every year they are graduating. Then also they are now more increasing numbers into medical school. We are now having more students enrolling into medical education. And also a new institution has been developed in one of the districts where they are now training middle level healthcare providers, and they are trained in basic surgical skills in one of the districts. And these are the ones actually supporting in terms of tax shifting at some of the district facilities. Then also more infrastructural work is underway, thanks for the support of our partners and the government of the people of Sierra Leone. So currently, although, you know, when facilities are being built, people easily flood them. But at least we have like 3 additional maternity centers now in Freetown, and some districts are expanding. Then the other thing that we have started now is some awareness have been created around quality of care. And I have seen a lot of partner interest in quality of care, even some of the projects or programs that maybe are not interested, but they have now trying to see how they use the quality improvement lens to actually implement their programs. Then the other question, whether TBAs are part of our health system. Well, formally, no. I would say formally, no. Informally, they are now in their communities working as like health mobilizers, because no matter what, we cannot decide for the women. They still recognize them, but they are not part of our formal health system wherein they can be paid for. I hope I am able to maybe respond to the questions. Biniam, do you have anything to say? Okay.
Excellent. Excellent, Margaret, and also encouraging to hear, based from the experience of the Ebola and other healthcare system shocks, that trying to build back better is possible, which I think would be very much in line with how countries now will be able to react on COVID, etc. Then it's also, we've had some question in regards to QAC program for MNH, but also other programs. So I have two questions, and one is if the QAC program is a standalone unit in the Ministry of Health, and what is the relationship with, for example, the RMNCH program? And in relation to that question, we also have another one that what are your reflections on how learning on quality of care for MNCH can be used by other programs and health services to improve the quality of care? So
Okay.
about both, relationship with other programs, but also in terms of scaling up and sharing experience with other programs.
Okay, thank you very much for those questions. QAC program is within the RMNCH as a program. It's a standalone, but it is within the directorate of RMNCH. The reason is we are using RMNCH as a driver to drive in quality within our health system. Though it is a health system strengthening program, but we are using the RMNCH driver or business case to drive, because for obvious reasons, you still know that Sierra Leone has poor health outcomes, poor RMNCH outcome. So we are using the RMNCH lens to drive in quality. So standalone program, but it is within the Directorate of Reproductive and Child Health, where relationship with the RMNCH, I think I have mentioned. Within the directorate, we have like the RHFP program, we have the adolescent and teenage pregnancy, we have the child health and EPI, then we have the quality management program that works with all of them. And we are using the RMNCH strategy, wherein it is clearly identified as one of the key strategic outputs. How can QAC learning be used for other programs? Yes, during the forum, actually, we shared the posters. And when we go to districts, other people actually are seeing the work that our QI teams are doing. And QI is discussed at all district health meetings. Quality of care is an agenda item, it's being discussed. And why not? People have started seeing improvement that they are seeing, and everybody wants improvement. So once they see that, they use. And some other programs actually, like very recently, I was working with the Global Fund, wherein they are looking at the 3 disease program areas. So I was part of their annual plan development, wherein some of the concepts we are now borrowing into the Global Fund disease program areas. And also some other programs actually, like this morning we were discussing the integrated surveillance supportive supervision system, the ISSB, and we want now to use, because going to unearth issues, it's just quality. You are using one of the approaches of root cause analysis. So what? So we are now using the QI interventions to see what some of the challenges that they met and how we can improve on them. So yes, we are also using the QOC lens to support other programs, although it's not been really easy. It's a lot of work and a lot of, you don't have life. So if I can put it, there is no life.
Great. Thank you. Excellent. Margaret, thank you very much for that. And as you explained in terms of the national structures and systems, we also had some questions which are more related to the district and facility structures. So one question is how the structure is in the district and hospitals. If you have selected QOC officers at the district level, at the facility level, at hospital levels, etc., or how the structure is at district and hospital facility level. And also now, in terms of the district, how many districts are you targeting now with this program, and are there any plans to scale up, both in terms of more districts for MSH, but also scaling up through in other programs?
Okay, thank you very much, Martin. So yes, sure. The structure of districts and QOC. So in each of the districts, actually Sierra Leone has like a 3-tier health system. You have national, you have district, then you have sub district. So at district level, we have the district health management team that we call DHMT. Then we have the hospital. Of course, yes, the hospital is the largest PHU within the DHMT, but it is independent. So in the hospital, we have a QOC officer, quality of care officer. That's what I'm saying. So these ones initially, each of the facilities, the hospitals, we brought them into out of site training, wherein a 1-week training was done. That's the standard in Sierra Leone for quality improvement. So after that training, we paired them. So any district, we have 2 from the facility, the hospital, and 2 from the DHMT. So we brought all of them into one forum and we trained them. Then they went back. Then when they went, they were now to go and set up their district committees. Because if you think for resources. So once they set up, then we follow them. And we did baseline data with all of them for us to know what is available currently before they can start their QI project. And they set up their team. So these are part of the offsite training where we train them how to select team, who should be team members, how the committee meeting should be held, and what they should discuss and how long it will take. So we now go and we witness them do that when they are available. So once we go, we see them do, then we try to observe and see where we can tie the knots for them to be able. So yes, those teams, if the hospital has like 11 units, you have labor ward, you have ANC admission, you have the antenatal clinic of itself, you have the outpatient or the triage, and you have the theater. So all those different units have their own different QOC committee. And out of the head of all those different committees, they now choose one person who should be the lead in that particular facility. And that is the person that takes part in the regular facility meeting and discuss QOC agenda after they have discussed with all the various teams. What I have shared as one of our challenges is when we have these people, once they are there, they either leave for further study or they are transferred to other areas. So that's why now we have appealed to the ministry for us to have dedicated QOC officer. Meaning once that person is there, we have developed a draft TOR that we shared and has been finalized. So that person has been appointed. That's one of the good news I got yesterday, that the chief medical officer has assented his consent and the director of RMNC. So moving forward, we are going to have dedicated QOC officers, which is good news for me. So that person should understand that at least once they have been appointed, they are people they are salaried workers. That person cannot just move like that. He has to have commitment to say, I have an agenda. So it's not like in a position wherein the quality of care work, there will be nobody, then you will go and find, oh, I have been to this place. No, that person is now going to have QOC as agenda. And I am also lobbying and moving so that that should be a position within the scheme of service that can be recognized. So people can develop career pathway in quality of care. In terms of PHU level, it's the same thing that applies. You have the QOC officer within the district health management team, that is at district. But at sub-district, now facility level, the PHUs, they also now were trained and they went back and set up their teams as well. You know, in that particular, it's just like providing services at least for 24-hour basis, but they do observation for 48 hours, then they refer to the hospital. So they also used the same QI approaches to do their root cause analysis and now came up with challenges. They prioritized and they started working on it. So you have one person that is fully trained and you have QOC committee members, and that person on a monthly basis moves from that facility and comes to the district level where they share their experiences and their QOC projects. Then how many districts? Sierra Leone has got 16 districts, but we are, before the 16 districts, we used to have 14. So out of 14, 6 districts were selected with a preset criteria for them to become our learning district. And in those learning districts, we selected learning sites. And the learning site, purposively, the hospital is one of the learning sites, plus 4 PHUs within those districts. So a total of initially 36. But because we have issues around supportive supervision and mentoring or coaching, we had to reduce them to 25. So we are able to really monitor and manage them. So I don't know. Plans of scaling up, yes, but we want to see at least the end of our next conference so that we can move. Then we want to see, now with the appointment of these dedicated officers, how we'll be winning them gradually, because it's too much on us to be going to those districts, those facilities to be supervising, monitoring, and coaching. So the more QOC officers we have, the more commitment we see, we will see how they will be supporting also in those other districts in terms of follow-up and also supporting for us to have. So I want to thank you. I hope I'm able to respond.
Excellent, Margaret. Thank you very much. I know you've been talking a lot for the past hour, but I have 2 more questions for you, if that's okay, before we wrap up.
Yeah, sure.
So one would be, what is the next immediate action to take in Sierra Leone? And finally, what is the key lessons that you have learned from this work?
The immediate next, severally, but as a priority, we are actually trying to see how we can maybe scale up with our activities that we have been doing. Then also to undertake a patient safety assessment in some selected facilities so we can determine the magnitude of patient safety or harm in these learning facilities. Then we want to see how we can scale up the experience of care and how we support regulation. Because no matter what we do, if people are not accountable to the end users, even though their experiences, the dissatisfaction or neglect is happening, nobody will be held accountable. And also, as a country, we really want to see wherein Sierra Leone will be able to really showcase how quality of care can be used to really mitigate or reduce the needless death of Sierra Leoneans. Then I really want to see the innate, let people see quality as being something that can help them. Because no matter what happens, COVID has shown a very good lesson. Even you have money, because of COVID restrictions, you will not be able to travel to the next neighboring country. I really want to see how our facilities can become friendly so that if you fall ill within Sierra Leone, you love to go there rather than people not wanting to get to our facilities.
Excellent. Thank you, Margaret. And just if you...
Well, you asked me another question.
Yes,
what has been personal experience? Honestly, I am enjoying the quality of care work. I have been in maternal mortality for like ages, but with quality of care, it has given me a new career pathway that I really don't want to leave. I think you guys did very well to really make sure we learn from, because quality of care, QI work is life. It's like science. You see it, you believe it. Because once you use the methodologies, you see where you have been making mistakes, where you have been making error, and compassion becomes part and parcel of you because you feel it. And the people, when we did the experience of care pilot study, you really hear people talking, you hear them saying. And I think, you know, it's something that Sierra Leone can jump. If we really want to reduce maternal and newborn deaths and also the suffering of our Sierra Leonean people, we have to believe in quality of care and we have to believe in quality improvement. It's a human right. It's a right for people to be treated nicely. It's a right for people to be involved into their care. It's a right for you to become accountable for whatever resources that have been spent or you are using. So I think, personally, I don't think I'll leave this particular fight. I don't think. Thank you so much for this opportunity. And thank you, Sierra Leone. And thanks to the Ministry of Health for giving me this opportunity. Well,
thank you so much, Matron Margaret, for both for all the great initiative taking place in Sierra Leone, which you're leading together with the MNCH and the partners, but also for taking the time to present to us all here on the amazing learning experience from Sierra Leone. And as I mentioned before, you're in the forefront now in terms of the national forums, and the lessons learned from Sierra Leone will also influence the future national forums within other network countries. So we once again very grateful for you doing this, and wish you all the best in the coming work, and we will work together on this. So just for some closing, I will hand over to Olive Kokoman again.
Thanks so much, Martin, for your great facilitation. And thank you so very much to Margaret and to Vivian from the WHO Country Office for you heard answer questions. I have to share with you what's been coming up in the chat box. Everybody is saying very exciting findings from Sierra Leone. This is brilliant. This is impressive, very impressive, insightful, informative. Congratulations. So much work has been done. Keep up the good work. Thank you for your leadership. Okay. And there's so much here for other countries to learn from. So, you know, we just have to acknowledge those statements to say thank you. Honestly, Margaret, this was just fantastic. We thank you for your powerful presentation, for sharing this really important learning. It couldn't be a better first webinar to set the tone for the National Forum Learning Series. So we just thank you so much for your engagement. We look so much forward to working with you moving forward. We will be sharing the presentation slides and this recording with all the participants and of course, more broadly on the network website, so it could be shared. And we will have, I think I have one more slide to say that Ethiopia has also hosted their national forum. We so look forward to the opportunity to share those findings from Ethiopia. That will be in September. We're taking a little break for the school holiday period. Margaret, I hope you're getting a break and a rest to build back up your power. You are just amazing. And thank you again. And you can follow us here on the website. And for me, that's it. Any final words, Margaret? You're just muted.
I want to use this opportunity to really thank the Ministry of Health and Sanitation and the government of Sierra Leone, that they did not make no mistake. They have seen quality of care. I want them to maintain the momentum. That is something that is a game changer. Then also to thank my partners, particularly WHO and WHO country office, and also Afro regional office and the QED network for actually making this happen. Then also other partners, UNFPA, UNICEF, PIH, QAM, MCGL Momentum currently, and several more. Then also my QOC officers and QI teams at district and sub-district levels. You guys are amazing. It's your story I am able to tell today. So keep up the good work. Let's believe in QI. There is no money to be paid for you to do good job. Let's do good work so that we are able at least to reduce the needless deaths and suffering of Sierra Leoneans. So thank you very much, Global QED Network. Thank you, Martin. Thank you, Olive, and all other colleagues that I cannot mention. And my participants today. Without you, this wouldn't have happened. Thank you for joining in.
Thank you.